Hello again. Welcome back. We are excited to have you join us for Culture and Power in Maternal and Child Health. Before we start again, I want to go over those notes again regarding the use of Zoom for our sessions today. For those of you who have been here all day, this is just a reminder as others may have joined us later in the day. First off, our summit today is being recorded. We ask that you please keep your microphones off while the speaker is speaking. You're welcome to have your cameras on or off throughout the day, but we encourage you to have them on when asking questions. We have a Q&A portion at the end of each session, and for those times and for sessions that are more interactive, please use the hand raise emoji to request to speak. On a computer, you can find the hand raise emoji in reactions at the bottom of your Zoom screen. On a phone, you can find it by tapping more in the bottom right and then the hand raise option. If you need help, the name of the tech support person will be near the top of your chat box in each session. You can direct message them if you have any questions. And the chat is also a great way to interact with other attendees in your sessions. Please also review our legal disclaimer that is found on your screen. And here are our financial disclosures for this talk. I would now love to introduce you to our next presenter, Lindsay Love. Lindsay Love is a licensed clinical social worker with a master's in social work from the University of Southern California. Dedicated to social justice issues, she works closely with teens and adults experiencing trauma and endeavors to create safe spaces for marginalized voices. This is why Lindsay opened up her private practice, Therapy Love PLLC, with the purpose of centering marginalized people and experiences that are not centered in traditional healing narratives. Lindsay values the diverse stories from within her community as she recognizes the strengths of individuals and groups. Using her positions on the Chandler Unified School District Governing Board and as the immediate president of ASBA Black Alliance president, Lindsay prioritized mental health, equity with an anti-racism lens, and LGBTQIA+ protections. Lindsay has led racialized trauma trainings for the Black Alliance, community mental health agencies, Venera Leadership Academy for Young Girls, and the Health is Queer Resistance series with Equality Arizona. Lindsay graduated from Emerge Arizona in 2018 and went on to become the president of their board in 2019 to support Democratic women running for office. Lindsay believes in the importance of having a seat at the table. As a true social worker, Lindsay is dedicated to dismantling systems of oppression that maintain power over oppressed groups. Disrupt. We are so excited to hear from you today, Lindsay. I will turn the time over to you.
All right. Hey, good morning, everyone. I'm just going to bring my presentation up really quickly. Okay. All right. Let me just see if it will share. Well, that is not it, but I will stop sharing and share the correct tab with you all. This is what happens when you have so many tabs up at once. All right. Okay. Okay. There we go. There we go. Can you guys see everything and hear me clearly?
Yes.
All right, good. So yeah, I am presenting this morning, and I'm assuming we're all in Arizona this morning. If not, good afternoon, wherever you are, on culture and power in maternal mental health. So just kind of like the objective of this session is to explore the impact of systemic oppression on marginalized people, especially like marginalized, like birthing people, and just kind of how to read between the lines and understand what a client might be carrying when they come into your exam room or wherever you're meeting them. And so, as stated, a little bit about me. I've been a licensed clinical social worker for over 10 years. I've worked the whole life spectrum at various points in my life, but I ended up working 16 and up, and I love working with people impacted by oppression because there's not enough of us out there doing that work, which is how I started my practice, Therapy Love. I became EMDR certified because I fully believe that in order to serve historically marginalized people, you have to be a trauma therapist. Um, and it's why I also like train the therapists that I supervise as a board approved clinical supervisor on trauma and understanding that in oppressed populations. I'm also a consultant in training for EMDR with the goal of making sure more folks from historically marginalized groups have access to this modality because it is useful and incorporates like different parts of our indigenous and Afro-Indigenous ways of healing that were robbed from us by colonialism. Um, and as being an EMDR trained consultant, EMDR trainings and consultation, they are very expensive, and keeping this modality out of the reach of therapists from historically marginalized groups, just really is tough for me as a social worker. So I want to make sure that um, we give this back to the people who it could benefit. And as shared, I was a past school board member in the Chandler Unified School District. And I also have my oppression trauma from that experience and many other experiences in my life, but fat phobia and death threats and racism for the 4 years that I was on the board. So I really believe that having that knowledge of your clients and where they've been before they enter your space and what they've been experiencing, because we know that these experiences do impact our physical and mental health, is supremely important. So just my three asks for this presentation. As I mentioned before, I'm an EMDR certified therapist. So I see things using what we call like an adaptive information processing approach, which means that like unhealed traumatic memories are stored in the brain and ultimately lead to maladaptive responses. And so what that means for you, bottom line, is our responses when we hear things that are difficult sometimes go beyond this room in this moment. And Resima Medicum, he talks about this notion of white body supremacy, in which white bodies will reflexively constrict in order to protect them from some of the truths they'll encounter, followed by the thought of I'm not like that and I'm a good person. If you have a BIPOC or marginalized body in any other way, you may experience recognition, clarity, anger, joy, and a rush of really intense emotions. I just ask that you notice your body in this space and during this presentation and ask yourself, what am I feeling in my body? What emotions are coming up for me? And what does that say about me? Or what am I telling myself to get myself to that level of disturbance? Those parts that reside within us may come forward during this conversation and be in conflict with each other, even be in conflict with me, and that's okay. Some things we hear that are new are difficult to swallow, and it's okay to explore where that comes from. And I'm definitely open and receptive to any questions that you may have. Also, as a caveat, I'm sick this morning, and so my voice may go in and out, or I may cough or sneeze. Please bear with me. I have all of the liquids and cough drops with me, but please let me know if I need to talk louder as well. But in this picture, we're looking at the Combahee River Collective. And this was a group of radical Black lesbian feminist, anti-imperialist, and anti-capitalist who formed in the 1974 And they named themselves after Harriet Tubman's 1853 raid on the Combahee River in South Carolina that freed 750 enslaved people. These women in this picture believe that white feminist orgs did not address racism in the United States, but that the identification of racism alone was insufficient politically to address their lived experiences of Black women, particularly Black women at the intersections of race, class, gender, sexuality, ability, etc., which is where we get that term identity politics from. They believe that the most profound and potentially most radical politics come directly out of their own identities as opposed to working to end somebody else's oppression. So I want to just say their names from left to right. At the bottom, we have Demita Frazier and Helen Stewart. From left to right at the top, we have Margot Okasawa, Ray, Barbara Smith, Beverly Smith, Shirlene McCrae, and Mercedes Tompkins. And I want to throw a quote at you from the Combahee River Collective and ask you to think about it and maybe jot some perspectives down in the chat. But their quote was, if Black women were free, it would mean that everyone else would have to be free, since our freedom would necessitate all of the destruction of all of the systems of oppression. And so I want you to just kind of like sit with that, right? And what that means for you as a provider in working with pregnant people who may come from a marginalized group or may come from, or identify as Black or African. And asking ourselves, is this really radical thinking, especially when we're seeing such statistically significant increases for non-Hispanic Black women when it comes to maternal mortality? This chart is telling us that while the increases from 2020 to 2021 were significant for all races and Hispanic origin, the rates for Black women were significantly higher than their white and Hispanic counterparts. And Black infant mortality, which infant mortality, as we know, is defined as the death of an infant before his or her first birthday. The infant mortality rate is the number of infant deaths for every 1,000 live births. And we see in this chart that non-Hispanic Black Africans have 2.4 times the infant mortality rate as non-Hispanic whites. Non-Hispanic Black African American infants are almost 4 times as likely to die from complications related to low birth weight as compared to non-Hispanic white infants. Non-Hispanic Black African American infants have 2.9 times the sudden infant death syndrome rate, mortality rate as non-Hispanic whites, and that was something that we discovered in 2020. And in 2020, non-Hispanic Black African American mothers were twice as likely to receive late or no prenatal care as compared to non-Hispanic white mothers. And this goes far beyond the numbers we're showing in 2019 and 2020. This is a legacy of historical injustices that continue to come and affect like health outcomes. When you consider the historical backdrop around Black babies and pregnancy, going back to slavery, we saw enslaved women enduring physical strain combined with malnutrition, inadequate health care, placing them at risk of miscarriage and stillbirth. In fact, the Gullah Geechee language had developed 2 words to describe a firstborn child, which was Fuss One, which was first one, and Comsi, which was firstborn child that lived. And even if enslaved women were able to carry a pregnancy to term, the conditions in which enslaved infants were born and raised often led to high infant mortality rates. Environmental concerns such as weather, overcrowding, unsanitized living spaces, malnourishment, etc., place babies at increased risk of communicable diseases such as respiratory infections, gastrointestinal illnesses, and skin infections, leading to their death. And in Florida, Black babies were often kidnapped and used as alligator bait because alligator skin was profitable and fashionable, and Black babies were seen as more expendable. All of this to say, historical values regarding the survival of Black babies have been influenced by systemic racism, economic interests, and social attitudes. Slaveholders viewed enslaved infants primarily as future laborers, and their survival was valued primarily for economic reasons and not their humanity. And when we see this trend continue we see this trend continue post emancipation, during Jim Crow, during the civil rights movement, where we started talking about these disparities in infant mortality. And today, where we have all of these advancements in technology and medicine, yet we still are only just having the conversations about infant mortality with delayed action. We live in a time where conversations around concepts of anti-racism and diversity, equity, and inclusion are being shut down due to uncomfortable feelings. But feelings should not be outweighing the need to save lives. And this is not the time to revert back to colorblind ways of being and thinking. MLK's dream, Martin Luther King Jr., it was never colorblindness. And it did not center having polite conversations while ignoring the issue of racial disparities in healthcare. In fact, he was calling out discrimination at Chicago Hospital, noting that the Negro infant mortality rate then in the Woodlawn area was as bad as it was in Mississippi. And he said famously, of all forms of discrimination and inequalities, injustice in health is the most shocking and inhuman. We have to be curious if these stats might reveal that when we feel we are not seeing color, we are literally erasing the existence and humanity of Black birthing people and their babies. We've got groundbreaking research out of the University of Minnesota School of Public Health, which they combed through 1.8 million Florida hospital births between 1992 and 2015, finding that although Black newborns are 3 times as likely to die compared to white newborns, when the doctor of record for Black newborn babies, which could include pediatricians, neonatologists, and family practitioners, was also Black, their mortality rate as compared to white newborns was cut in half. So, though more research needs to be done in understanding this correlation and why we don't see the same trend when doctors or of record their race match the newborns of other races. What's clear is we are not addressing the needs and care of Black babies and families adequately. And for this presentation, I want to unapologetically center us around this belief that our healthcare system, like other systems, do a poor job at centering the experiences of our most marginalized people. And if we start with our most marginalized folks, as the Combahee River Collective alluded to, it might lead to better outcomes for everyone. But this is not your individual fault, right? This is a systemic issue that is purely by design, as there were forces involved in shaping these systems that predate any of us, but still have an impact on all of us presently. And in order for us to support pregnant people from all backgrounds, we have to acknowledge the existence of systemic oppression. And so let's define that term. So, systemic oppression refers to the pervasive institutional and structural discrimination faced by marginalized groups within various societal systems. This might be embedded in our policies and practices at organizations we work within that perpetuate further repression. So, some examples of that is think about how some policies have changed or shifted recently with this overturn of Roe v. Wade and Planned Parenthood versus Casey. These are just kind of like some headlines that I snipped that we've seen from 2022 to present in terms of how this has impacted us and impacted pregnant people. Um, and I'm sure that as medical providers, you've likely seen changes that have led to reporting pregnant people to the police or changes in treatment protocols around miscarriages as states have enacted more restrictive anti abortion laws. AZ in particular has a few abortion laws on the books from 1864 that were triggered once the overturn of Roe took place. And we're seeing an increase in pregnant people being criminalized and arrested in states with more restrictive bans. But who does this impact? People who are more marginalized, such as those who are poor, BIPOC, disabled, queer, and others who may struggle with access to care. This is what we're seeing. And when we ignore the existence of systemic oppression, we condemn people to inadequate care and continue medical oppression. And before we get into defining that term, medical oppression, I want us to kind of like define like what oppression is at its base. So Merlin Fry, he conceptualized oppression as a means of immobilizing a group of people and reducing their options for behaviors while also requiring complicit compliance to this limitation and immobilization. We're going to look at it as a societal force or as societal forces that are responsible for prolonged, repeated, widespread systemic injustices of groups of people while also elevating and providing opportunities to other more dominant groups. So, simply put, there can be no oppressed group without a directly affected privileged group. And we need to see oppression as a form of trauma, as it can result in disembodiment and dissociation, which does not have great impacts for our physical and emotional health. And it does not have great impacts for the physical and emotional health of babies. But let's think of like and be clear of like who our oppressed groups are. And if you would engage me in like typing who you think those groups are into the chat. Um, that way we can know and identify about who we visualize. Hold on one second. I think I have to scroll down. There we go. Oh, apparently I have to scroll way down. Okay. So Native Americans is one that I've seen. um, Black Indigenous people of color. Yeah, like those are, a few groups, right? Black Indigenous people of color or LGBTQ populations. We also have poor and houseless people, right? Um, People who have disabilities, youth and children, right? Uninsured, underinsured, Medicaid members, yeah. People who have been diagnosed with a mental illness, 18 and younger, yeah. Also, too, like immigrants, we also don't talk about fat people, right? And sizeism is actually not on this chart, but it's definitely one we need to look at because it does actively contribute to harm. That's another presentation for another day. But experiences of birthing people who are pregnant or who are fat and aside, quality of healthcare goes down. I think somebody said people who are substance users, pregnant teens, and adolescents. So this is all a really great list, right? Um, People who are non-Christian. That's also one. People without college degrees, people who don't speak English, right? What's important to know is that oppression results in harmful outcomes that impacts our physical and mental health, as we said. And if we understand that when a client with one or more intersecting identities walks in the room, we can tailor our approach to care to their needs. So let's define medical oppression. Medical oppression refers to the systemic and institutionalized discrimination, bias, and mistreatment experienced by marginalized groups within the healthcare system. So, the importance in understanding medical oppression is because it's crucial for healthcare professionals to ensure equitable care for all patients, right? And to understand where maybe their own biases are. So, different forms of medical oppression include, like, some common ones like implicit bias, which we've heard a lot about, um, which are like your unconscious stereotypes that influencing like medical decisions, racial and ethnic disparities in in healthcare access and outcome. So we also have gender bias, which is differences in the treatment for men and women and LGBTQ plus folks, discrimination in healthcare settings. We also have ableism, which is neglecting the need of people with disabilities, as we know. And then we also need to talk about like historical examples of medical oppression, right? So we have the Tuskegee syphilis study, which I'm sure that you've all heard about, which is represented in the picture at the top middle. We've got forced sterilization of Indigenous and Black women, more specifically in the picture in the middle at the bottom, Puerto Rican women. That's what's pictured. Though we're still hearing about forced sterilization cases across the country. Most recent and prominent was with women detained at the border, or pregnant people detained at the border. Also, California stopped forced sterilization of people in prisons in 2010 due to the state eugenics laws that had been on the books since 1930 and resulted in 20,000 people being sterilized in state hospitals and prisons finally being repealed. We also have Henrietta Lacks, who is at our top right, and unethical practices in cervical cancer and HPV research. So her HeLa cells, of course, we know were taken from her without her knowledge or consent, and without her family's knowledge and consent. And if you haven't read the book about like how that impacted her family, years later who not have access to healthcare, but their mother or descendant cells or ancestor cells were being used to help advance medical research and cure certain ailments and create certain treatments for others that her family had no access to. J. Sims and his surgical experiments on enslaved women. And I want to just name those women, Anarcha, Betsy, and Lucy. And then we also like countless violations towards disabled people, which includes some forced sterilization and forced institutionalization of disabled people instead of adequate medical care and treatment. Um, and then lack of funding, of course, to the research of treatment options for HIV/AIDS, countless other ethical violations in medical experiments. Those are some examples of like medical oppression offhand. But acknowledging past injustices helps us prevent their recurrence. But they also might help you as medical professionals to understand what your patients are walking in the door with. But we can't sweep the knowledge of these historical examples under the rug and misidentify them as things that happened in the past. They have real implications on the care and treatment that your clients from historically marginalized communities receive today. Like medical education has historically perpetuated stereotypes about gender, race, sexuality, and disability because unfortunately eugenics was given legitimacy in science, and the influence of eugenics era content in on modern medical school curriculum is a complex and controversial topic. And while explicit eugenics teachings have largely been removed from medical education, some of the elements of that era, such as the study of genetics, population health, and ethics, continue to be taught, but in more ethical and responsible ways. However, many medical schools do have curriculum that continue to contribute to medical oppression and health disparities. While efforts have been made to address these issues, it's important to acknowledge that disparities in healthcare persist because of that. So like a few racial stereotypes. So there was a stereotype that Black people are more resistant to pain, and this comes from beliefs out of slavery. In fact, during slavery, rascality was a term essentially used by overseers to describe lazy slaves. And like the recommended treatment was to bathe them, slather them in oil, and beat them with a broad strap, then put them to hard work in the sunshine. And of course, like that pain belief was also something that J. Merriam Sims used in his painful experiments on Black enslaved women without anesthesia. Um, but today, there are countless well, also too, I want to also put in like not just physical pain we're looking at. I also want to talk about emotional pain too, and how emotional pain is kind of underscored in communities of color as well. Um, Going back to like the dawn of time, because we have a tendency to dehumanize the pain of racialized people. Like even like slave ship narratives. Enslaved people would sing on the Middle Passage, because that was a part of their indigenous healing practices, and that was how they would cope with the torture of being abducted, and kidnapped. And they were told to be silent and punished for that, on those ships. And then we also saw people throwing themselves off of those ships because they believed that suicide was relief and return to home, right? Those impacts and today lead to like inadequate pain management for Black and Brown patients, um, contributing to like disparities in like pain treatment. And in fact, a study published in 2019 out of the University of North Carolina looked at whether the frequency of pain assessment treatment differed by patient race and ethnicity for women after cesarean sections. What they found was that Black and Hispanic women were less frequently evaluated for pain. They often had higher pain scores, yet received less pain medication than white women. And those differences didn't go away with considering other clinical factors, suggesting that racial inequities here are the result of differences in delivery of care. So that is also very important and fits with like studies on racial bias in pain assessment and treatment recommendations from other past studies as well. Um, Also, oh, before I mention that, since we're also talking about emotional pain too, we're more likely to punish BIPOC people for their symptoms of mental health issues, right? For depression, PTSD, anxiety, as opposed to offering treatment. And so we have BIPOC folks who never get a referral for mental health treatment and services. Yet we are seeing increases in suicide for these populations as well. We tend to punish those behaviors. So, real impacts. And then, of course, like gender stereotypes. So, women are more likely to be seen as hysterical or emotionally unstable, which impacts like gender bias in healthcare that results in like dismissal of women's pain and emotional distress, leading to inadequate care. There was a lawsuit at Yale University where the pain of women during egg retrieval was dismissed until they found out that a nurse was stealing vials of fentanyl meant for medical procedures and replacing it with saline. So these women's pain was just like dismissed, and they were reporting some very horrific um, like side effects from this, and it was ignored for years. Um, Gender bias in physician responses to chest pain too is something that we're seeing. So according to the Journal of American Heart Association, Women who visited emergency departments with chest pain tended to wait 29% longer than men to be evaluated for heart attacks. And there are also a few studies that show that middle aged women with symptoms of heart disease are often diagnosed with mental illnesses and their symptoms go completely ignored. And we've had some like real life examples of this in the media. So I don't know if you guys remember like Serena Williams and her alerting doctors to her history of pulmonary embolism and being outright ignored by the nurse and medical doctor when she was telling them her symptoms and what she needed. And then like NPR and ProPublica had their like breaking story of severe preeclampsia and how that gets ignored in medical follow-ups and isn't adequately addressed in terms of like looking at high blood pressure screenings early on in checkups and following through with like protocols to address that, and also ignoring like pain symptoms reported by childbearing people after the birth and being written off as gas. um, the US, of course, is said has the worst maternal health rate in the world. According to advocates, we simply aren't treating labor as seriously as we could because we operate under the assumption childbirth is a normal process and the body will just bounce back, though we know it takes a year for the body, if not more, to recover from childbirth. And then, of course, like stereotypes around like our LGBTQ folks, right? Um, so the biggest impact that we see in the research is we don't see anything involving like LGBTQ plus folks in terms of like the medical research, because most of our medical research is done through a heteronormative lens. And it's, these kind of lead to like difficulties too when you have queer folks who are pregnant and parenting and they're unable to provide or find providers who are willing to work with them. As a matter of fact, I've worked with a lot of clients who doctors have told them, I can't work with you on your specific issue because I don't know about your kind. And they're going in for like ear infections or, because they are pregnant. And so we have difficulties with finding the help. And then we also see an increase in PMADs, which is your perinatal mood and anxiety disorders, and increase in suicide attempts with lesbian women. And like trans folks, they report significant amounts of discrimination and lack of training and awareness, anecdotally in the healthcare system. And then stereotypes around like disabilities. So people with disabilities are often said to be dependent and lack capacity for decision making. And this was a belief directly out of the eugenics movement and led to some forced sterilization. Today, the stereotype can lead to a lack of respect for autonomy and limited access to healthcare for people with disabilities, especially those who are pregnant. In fact, women with physical disabilities tend to perceive um, providers of reproductive health as holding negative attitudes regarding sexuality, motherhood, and childbearing. And there have been a number of studies that show that women with physical disabilities encounter doctors who didn't know their specific disability in general and how it impacted their pregnancy. And there were also inaccessible equipment in the office, such as scales and exam tables as well. And then also examining like intersectional identities, and the multiple oppressions that lead to compounded health outcomes, right? So those living within those intersections of these identities may face some unique challenges that are not adequately addressed within the healthcare system. Um, like countless studies. So just imagine like having one, oppressive group having a problem, but then like being at the intersection of multiple, it makes things a little hairy. So knowing all of this, hopefully this changes the way you see your patients when they come in the exam room and what they're carrying in. They're complex human beings with a ton of lived experiences that might include trauma, their own personal trauma that they might be carrying, or trauma from generations prior. and they have their experiences of discrimination and their own stigma and shame, likely. Some of them may fear you as medical professionals due to past experiences with other medical professionals or even historical harms that were done to the communities they closely align with. Instead of avoidance, we want to like question what we need to ask ourselves and ask our clients as we enter or they enter the exam room. So, cultural humility and practicing that. Just throw away the term cultural competency because I feel like that puts too much onto providers to know everything about a person when they show up and their culture in the room. But being culturally humble, right? And being open to learning about different cultures and different experiences within a culture, right? Because all of the identities that we cover today, um, they are not a monolith, right? And there are variations to human experiences. But centering that cultural humility, recognizing that, I don't know it all, but I'm willing to learn and being committed to training and holding space for your clients is key, as well as those components of self awareness, respect, and open mindedness. Um, Recognizing that there are power imbalances between you and your client and even your historically marginalized patients in the systems they interact with. And then also providing that safety for your client to be able to share parts of their identity and how that might impact them is important.
Lindsay,
Um,
sorry to interrupt,
there's
Lindsay.
also,
Oh, sorry. Can you hear me?
can you hear me?
Oh, yes, sorry. I want to leave a little time for questions, but I want to see if there are any questions, Raquel, or did you have something? Do you have a spot you'd prefer to wrap up at?
Yeah, I'm almost done, right? So I just want to talk about assessments as well. So using like different assessment tools in intake too. So we know the ACEs, but there's also the Philadelphia Expanded ACE questionnaire that looks at community level adversities. That might be something to consider putting into your intake paperwork with clients. And then also being mindful of like intergenerational and epigenetic trauma, which I don't think that I have to explain here. But you are doing work to break cycles with, you have two generations in front of you when you're working with pregnant people, right? And this is work that is about breaking cycles. And then also too, like I think you guys will post the rest of these slides, but asking appropriate questions in assessment, right? So, cultural and background identity questions, asking about past trauma and depression directly, and then like mental health and emotional well being, making those referrals to like different systems because you don't have to do it alone. Using doulas, midwives, dietitians, therapists, so that we can engage in collaborative care. And then also making sure that your front desk staff are open to learning and aware of the fact that they can be the client's first entry into services and make them feel safe. So I think that's all I have right now. Questions?
Yeah, thank you so much for sharing all this important information with us that we all need to hear. Um, we have, I think we have at least one question in the chat, and if anybody has any questions, please use the raise hand emoji so we can have the moderator call on you.
We've got one question in chat. Thank you so much for that information. It was so important. The question we have is, what are we doing now to prevent these issues from happening? And are we helping those who have experienced these issues?
Like issues in terms of like oppression in these systems or people slipping through the cracks.
Yes.
Okay. Well, and I think that PSI is doing a really lovely job too with making sure that they are training as many providers as possible, especially providers from different and diverse backgrounds too, to make sure that there are more providers who are aware of the problems that people from oppressed backgrounds experience, right? There's a number of advocacy things that are happening, right? But we're also in a time where a lot of those conversations are being shut down, right? Like 2020 was supposed to be this year of racial reckoning, right? And we started having these conversations about maternal mortality before that, and even strongly during 2020, right? But we're seeing kind of like this backlash, right? So not a lot, right? Because this backlash is shutting things down. Like I just went to a Planned Parenthood luncheon, and a lot of the things that we're seeing with regards to like the rolling back of abortion laws, it doesn't just impact abortion, right? But it impacts pregnant people in general. And this rollback of a lot of these laws in our states impact people from marginalized communities the most, who have the lack of access to healthcare, right? And so it's looking pretty bleak right now, right? In terms of like access to care, criminalizing people, pregnant people, right? It's creating significant gaps and mistrust with the healthcare system. Um, we could talk about how you guys can do your individual part, but yeah, there's going to be some challenges for you as providers based off of what the state is saying, and um, who's around you, and like how you can do these things, by yourself. Like it does feel insurmountable, right? And so I guess that's something collectively to kind of like ask, like with medical providers, what is your commitment to advocacy with regards to your clients?
Thank you.
And as Tandy
Thank you.
mentioned, SI had its first full BIPOC training, which was lovely. I attended. But yeah, like I think also reaching out to some of your community stakeholders as well is important, to help with that advocacy piece.
Thanks so much, Lindsay. This was
Thank
such a powerful presentation. I really, really appreciate it. Really, I think it's a hugely important one for us to all hear as part of the ecosystem. So thank you.
You're welcome. There's so much information and it's hard to fit it into an hour, but of course, if anybody has any other questions, I am here.
Thank you. Thank you so much. Yeah, that's a good reminder to get active on the Whova platform so you can find more information about Lindsay there and reach out. And we have some time for a break. We are supposed to resume at 11:30. I don't know if we're gonna push a couple more minutes if people need to run, take a bathroom break, get a sip of water. Um, and then check out Whova and come back in a couple minutes. We'll be back here at 11:30.